Hello students, myself Dhekshika MG, Assistant Professor, Department of Anaesthesia Technology, School of Allied Health Science, Salem. So today's topic I am going to take is about airway equipments. Introduction. First we will see about what is airway equipment, for what purpose we are going to use the airway equipments. First is used to maintain, open and protect the airway to ensure the adequate ventilation and oxygen, during which purposes because of anesthesia, resuscitation and emergency care. During these three we will use airway equipments. So airway equipments are broadly classified into oropharyngeal airway, nasopharyngeal airway, supraglottic, infraglottic. Each is designed specifically for clinical situations, and how we will choose the patient according is based on patient's level of consciousness, risk of aspiration, duration of the procedure and clinical settings. Now we will see what is the definition of airway. Airway is nothing but an essential part of respiratory system which will allows the atmosphere air into the lungs, making us for normal breathing. Now we will see in depth about what is the airway equipments. So first we will be seeing about face mask. What is face mask? It is a method of delivering oxygen and inhalational anesthetic agent to patient through a face mask that is placed on the nose and mouth. Without using advanced airway like endotracheal tube, we are just placing an face mask which will allows us to give an oxygen and inhalational anesthetic gases to the patient. Now we will see about where all we will use this indication of face mask. First we will use for pre-oxygenation before induction of anesthesia. Next we will use for short surgical or diagnostic procedure. Then maintenance of anesthesia when intubating is not required, where we do not intubate the patient. Just by using a face mask we will give the maintenance of anesthesia for the patient. Next we will use for assist ventilation during sedation. Then emergency airway management and resuscitation. These are the indication where we will use this face mask. Then contraindication, where we should not use this face mask is first is for full stomach or high risk of aspiration patient. Next we will not use for severe facial trauma patient, upper airway obstruction, poor mask seal and uncooperative patient. These type of patient we should not use face mask. Then technique, how to use this face mask. First we have to select the appropriate size for the patient. Then connect the face mask to the anesthesia breathing circuit. Position the patient, that is position will be head in the sniffing position. Hold the mask firmly over the nose and the mouth using C and E technique. Now I will show how the C and E technique is we have to follow. As I show in the picture, this is C and E technique. The first one is C, that holds the nose and the chin. Then E will hold the jaw of the patient. This is the C and E technique. We have to hold the patient face mask and see whether the air is going properly to the patient. How we will confirm is by seeing the chest movement. Then assess ventilation if required using reservoir bag. Then we have types of face mask. In types of face mask we have black rubber face mask, transparent plastic face mask, silicone cushion face mask, antistatic face mask, pediatric and neonate face mask. Now we will see what are the complications during this face mask. Is hypoventilation or hypoxia, then gastric distension, aspiration of gastric contents, air leakage and inadequate ventilation, facial pressure injury or nerve compression, dryness or irritation of the eyes. These are the major complications when we use face mask. Now next we will see about oropharyngeal airway. What do you mean by oropharyngeal airway? Means it is the curved plastic device which is inserted through the mouth into the pharynx to prevent the tongue from falling back and obstructing the airway, thereby maintaining airway patency. So it is nothing but a plastic device which is inserted into our pharynx, which is used to prevent the falling back of the tongue. Now indication where all we use this face mask is mainly in unconscious patient with loss of protective airway reflex, airway obstruction due to tongue fall, then during bag mask ventilation, during general anesthesia, during CPR, and to facilitate suctioning of the airway. Now we have color coding for this oropharyngeal airway, that is size, color and uses we'll discuss now. First is size, that is 0. 0 is used for neonates and the color will be black. 1 is for infants, color is white. 2 is for children and it is in color green. And 3 is for small adult, yellow. 4 is for adult, red, and 5 is for large adult, that is blue. Based on the patient, we have to select the approximate size. Now, contraindication, where all we going to not use this oropharyngeal airway. That is mainly in conscious or semi-conscious patient, presence of gag reflex, oral or maxillofacial trauma, recent oral surgery. In this patient, we have to avoid oropharyngeal airway. Now, technique of inserting this oropharyngeal airway, we have to first, whatever the airway or anything is, we have to first select the correct size. So, select the correct size, open the patient mouth using a scissors technique. Insert the airway upward down, advance until the soft palate is passed. Then we have to rotate it to 180 degrees so that the cavity facing downwards. Ensure proper position and advance the ventilation, so that we have to give proper ventilation to the patient. Now, types of oropharyngeal airway, we have 3 types, that is Goodell's airway, Berman's airway and Williams airway, but most commonly we are using is Goodell's airway. Then complication of this airway is gagging and vomiting, aspiration, laryngospasm, dental and oral traumas, tongue injury or edema, worsening airway obstruction. If the proper of size is not, we are not choosing the correct proper of size, so it will be worsening of airway. Next we will see about nasopharyngeal airway. Nasopharyngeal airway is a soft tube inserted through the nose to keep the airway open by preventing tongue obstruction. It is inserted to the nose, as the word tells, nasopharyngeal, so it is inserted to the nose. Now we will see about indication. First indication is semi-conscious or conscious patient with intact gag reflex. Then upper airway obstruction due to tongue fall. Patient with restricted mouth opening during bag mask ventilation when oropharyngeal is contraindicated. Then facilitation of nasotracheal suctioning, emergency airway management. In this case, we will use nasopharyngeal airway. Now we will see color coding. Size 4 mm is dark green and size 5 is black. Size 6 is green, 7 is orange, 8 is dark red and 9 is purple. Now 6 color green is often used for small female adults. 7 is used, that is orange, standard adult size. 8 dark red often used for male. Next we will look into contraindication, where all we have to stop using this nasopharyngeal. Now first is for suspected any basal skull fracture, severe facial or nasal trauma, coagulopathy or bleeding disorder, nasal obstruction, recent nasal surgery. Now technique of insertion. How we will insert this nasopharyngeal airway. First, we have to select the appropriate size, then lubricate the airway with water-based gel. Position the patient, head should be neutral. Insert the airway gently into the nostril with a bevel pacing the nasal septum. Advance along the floor of the nose until the flange rests on the nostril. Then confirm airway patency and advance ventilation. Next we will see types of nasopharyngeal airway. We have 3 types, that is soft rubber nasopharyngeal airway, flanged nasopharyngeal airway, cuffed nasopharyngeal airway. Cuffed nasopharyngeal airway is rarely used. Now we are using soft rubber nasopharyngeal airway. Complications. Complications of using nasopharyngeal airway will be epistaxis, that is most common complication. Next is nasal mucus injury, incorrect placement into esophagus, laryngospasm, aspiration, infection with prolonged use. Next we will be looking into supraglottic airways. That is, supraglottic airways are airway device placed above the vocal cord that maintains airway patency by sealing around the larynx inlet, allowing ventilation without entering the trachea. It is just placed above the vocal cord to maintain the airway. Indications: airway management during general anesthesia, short surgical procedures, difficult or failed endotracheal intubation, emergency airway management during CPR, and control and spontaneous ventilation. Contraindication where we have to not use this: high risk of aspiration, that is full stomach and GERD patients, reduced mouth opening, upper airway obstruction below the larynx, then severe obesity, poor lung complaints or high airway pressure requirement, then oropharyngeal trauma. Technique of inserting this supraglottic airway: first we have to select the approximate size, that is based on the weight of the patient, check device integrity and deflate cuff, lubricate the posterior surface of the device. Position: it should be in the sniffing position. Insert along the hard palate until resistance is felt. Inflate cuff to recommended pressure, then confirm the placement. That placement of the tube will be confirmed by the chest rise, auscultation and capnograph. Then secure the device. In supraglottic airway we have type, that is first generation and second generation. In first generation we have classic LMA, LMA unique, then flexible LMA. In second generation we have intubating LMA, ProSeal LMA, Supreme LMA, iGel and LMA C-Trash. What is the difference between first generation and second generation is, in second generation we have a drainage port, a separate tube we have for draining the aspiration contents. Then complication using this supraglottic airway device is mainly like aspiration of gastric content, then sore throat and hoarseness, air leak and inadequate ventilation, laryngospasm, nerve injury, trauma to lips, tongue or pharynx, then gastric insufflation. Next is infraglottic airway device. Infraglottic airway device is placed below the vocal cord into the trachea to provide a secure airway, allows control ventilation and protect lung from aspiration. As we saw before is supraglottic airway device, that is placed below the vocal cord, this is placed above the vocal cord. Now indication why we use this ET tube or infraglottic airway device. So indication will be general anesthesia requiring a secured airway, long surgical procedure, patient at high risk of aspiration, mechanical ventilation in ICU, severe respiratory failure, and during CPR, that is advanced airway we have to give for the patient. So during that we will give this ET tube insertion. Now contraindications. Contraindication where we have to not use this ET tube is severe cervical spine injury, limited mouth opening, upper airway trauma, anatomical airway abnormalities. Then technique of ET tube. First technique is, before we have to insert the ET tube, give pre-oxygenation to the patient. That is 30 minutes we have to pre-oxygenate the patient using a face mask and a Bain circuit. We have to give pre-oxygenation, that is 3 minutes for the patient. Then position head in sniffing position, perform laryngoscope to visualize vocal cord. When you see the vocal cord, pass the endotracheal tube through the cords into a trachea. Then inflate the cuff. Confirm of the placement will be by chest rise, auscultation, capnograph. Secure the tube and connect it to the device. Types of infraglottic airway. Types we have endotracheal tube, tracheostomy and cricothyrotomy. Then complications we have. By using this ET tube, what are the complications patient related will come like esophageal intubation, hypoxemia, aspiration, dental and airway trauma, laryngospasm or bronchospasm, vocal cord injury, tracheal stenosis, sore throat and hoarseness. Thank you for watching my video.